This is Justine Sparrgrove recording Health Promotion for Women, Learning Plan 4, over chapters 3, 5, and 6. Please review chapter 7 on your own. Like I said, that should be a review since it pretty much just has the AMP of the reproductive systems. Genetic disorders. So sperm and egg cells contain 23 chromosomes. 22 of the chromosomes they're actually called autosomes and are inherited from each parent, which are non-sex chromosomes. And then one pair is the sex chromosomes X and Y. So a normal female karyotype, they have 46 chromosomes total. And then they have 2 X's, and normal male karyotype again is 46, but they have XY. So females are XX, males are XY. The entire DNA in a human is called the human genome. Each person's genome is unique except identical twins. They share identical DNA sets. So I want you to think about if 2 female twins marry 2 male twins, they have offsprings. Their offsprings would be like brothers and sisters because the DNA would be exactly the same from the father and the mother. Now, males usually determine the sex of the baby because females only carry the X chromosomes, whereas males carry either X or Y. So if you're female and you're wanting a boy or a girl, well, that's not entirely up to you. It's up to the male and what sperm makes its way through and whether it's got the X chromosome or the Y chromosome. Y chromosomes have few genes that are critical to life, but the X chromosome has many critical genes that would be duplicated in females from their XX chromosomes. So early on in the female embryonic development, within a few weeks of fertilization, one of her X chromosomes is inactivated. So let's talk about chromosomal abnormalities. So there's 3 that are the most common abnormalities. An increase or a decrease in chromosome number is called an aneuploid. Sometimes an error occurs during that cell division, and this usually happens during meiosis or during the reproductive cell's division. Someone may end up with 2 copies or 1 copy of a particular chromosome, and usually this results in early pregnancy loss. So the body automatically picks it up, realizes that something's not right, and then it aborts. Missing one member of a chromosome pair is called monosomic. Commonly, Turner syndrome is the only birth that can actually result from that. Otherwise, any other abnormalities there, missing one of the members of the chromosomes will automatically result in abortion. And then having 3 homologous chromosomes instead of the usual 2 is called trisomic. Down syndrome is the most common for chromosome 21. But others include Pateau syndrome, 13, Edwards syndrome, 18. And the prognosis is really poor for these children, and they usually present with cardiac and respiratory complications and die within the first 3 months. Now, when monosomy or a trisomy occur during mitosis or after fertilization, this results in 2 or more separate cell lines with different chromosomal makeup called mosaicism. So depending on how early the error occurred and to what chromosome it affected, the chromosome may be more severe or less severe. So an example would be a mosaic Down syndrome person may have a higher level of intelligence and may survive longer than the typical Down syndrome patient. All right, so let's talk about autosomal dominant inheritance. So dominance is a presence of a single altered gene allele that is enough to cause a disease. Or in other words, a person will have or express the disorder despite the presence of one normally functioning allele. So common diseases include neurofibromatosis, achondroplasia or dwarfism, Marfan syndrome, Huntington's disease, and familial hypercholesterolemia. And we also need to remind the parents that each pregnancy has the same exact chances that their baby will have the disease. So it doesn't change just because you have 2 children who have it. The other children can have it as well. So sometimes looking at this, let's talk about this picture first. So here's the mother, unaffected mother. She's got DD. We're using D for the word dominant here. But she's got 2 little d's. So she's what we call unaffected. Now the father has got the big D, which means that he's got the alteration, but he's also got a little d. Now in dominant inheritance, only one of these chromosomes needs to have the alteration. So he's got the alteration. That's what the big D stands for, is that alteration. So he's got it, and he only needed one to have the disease. So now we can look at the kids. So the picture's already done this for us, where it's broke down if they have kids, what the chances are of their kids actually having this dominant disease process. So when it breaks down, it comes to 50-50. Now there's another way to do it, and I like to use it this way because this picture, if I were to try and draw it out myself, I would get all confused. So I drew a Punnett square for you. So as you can see here, we have mom with her D, and dad with his little d and big D right here. And remember, this big D stands for dominant, that he has one chromosome that has the defect in it. So then I go ahead and I fill in my squares here where the red ones are. And I went D and D, made a double D. Little d, double D. Big D, little d, and big D and little d again. So now I can look at that and go, okay, what are my chances that my children will have this disease process? Well, I can clearly see it on here that I have 50-50 chance, because I have two here that have the big D that show the dominant, and so they can have the disease process, but I have two here that don't have anything. So that's a 50-50 chance. Now, let's move on to autosomal recessive disorders. So recessive disorders only occur if both alleles of a gene pair are altered or both copies of the same gene in an individual are altered. So you need two of them. So recessive conditions are more severe and have an earlier onset. So examples are cystic fibrosis, sickle cell, Tay-Sachs disease, and errors of metabolism. So both parents are carriers of the condition in this picture up here. And carriers don't exhibit signs or symptoms except those with sickle cell disease. So in extreme physical exertion or dehydration or high altitudes, they can develop symptoms. Otherwise, anyone else who is only a carrier, so only has a little r and a big R, will not display any symptoms whatsoever. So again, I went ahead and I drew my Punnett square. So mom she's got little r, and then she's got the big R. So meaning the big R here represents that she's got the altered gene. So one's unaltered and one is altered. And then dad has the same thing, one unaltered and one altered. It's showing the same thing here, just a little bit different picture. So then I went ahead and filled it in with my double R, double R, double R, double R. But now I want to know, what is my chances of my children either being carriers or being affected or not affected at all? So at first, I can see two little r's would indicate that they don't have that altered gene at all. So they have no chance of being a carrier or having it whatsoever. So they can't carry it on, give it on to anybody else in their family. Then next I look at my little r and my big R. So I only have one, so that means that I'm only a carrier. But I have two of them that have one of the altered genes in it. So 50% chance that my children will be a carrier, and 25% that they will have nothing to do with it, and then another 25% that they will have that disease process there. Let's talk about X-linked recessive disorders. So X-linked are from the altered gene on the X chromosome. So most are recessive, but remember that males only have one X chromosome, whereas females have two, and one becomes inactivated and can compensate for the other, making her a carrier. So if the male has a chromosome, has that chromosome specifically, he will most definitely have it and pass it on to all of his daughters, but not sons. Why is that? Well, if you recall, males have an XY chromosomes and females have XX. So if the male has is a carrier of it and has it on the X chromosome, he can't give the X chromosome to his son, he will automatically give the Y chromosome to his son. So the sons can't get it, but all of the daughters will have it because he'll automatically give an X to the daughter to make one of her X's. So some examples here would be like hemophilia A, Duchenne muscular dystrophy would be another one. And also remember that the Y chromosome has very few genes, so typically the genes associated with spermatogenesis is altered and can lead to infertility in males. So there's really not a whole lot that go wrong with the Y chromosome. And if something does go wrong, it's usually related to fertility. Let's talk about prenatal diagnostic tests. So ultrasounds can be done at 16 to 20 weeks. They can be done sooner, but for diagnostic testing purposes, they're usually done between 16 and 20 weeks, which then they can visualize the fetal head, spine, gastrointestinal, renal, and skeletal system for malformations. And it's usually done at this time because the fetal structures have fully developed completely. And they can do them earlier, but usually it's just to see, are they pregnant, and that the baby's growing, or is it alive and active? It's about all that they're really looking for earlier. Now, nuchal translucency measurements are fluid filled space at the back of the neck, and is done at 10 to 14 weeks because there's a high correlation with fetal chromosomal abnormalities. So the higher the fluid, that's associated with an increased risk for chromosomal abnormalities, birth defects, genetic syndromes, and poor pregnancy outcomes. They can also do serum alpha fetoprotein, and that's usually done in the first or second trimester, and it measures for specific hormones, proteins in the maternal serum, and it can also determine the risk for Downs, trisomy 18, or spina bifida. Now, another one that they can do is amniocentesis, which collects cells from the fetal origin and is collected through a needle that is inserted into the amniotic fluid, and this can be done after 15 weeks, but it has to be done under ultrasound, so they don't just put a needle in there and hope to shoot for what they're trying to get. They do use ultrasound for that. Chorionic villus sampling, or CVS, is also collected with a needle through the abdomen, or it can be done through the cervix and collects placental tissue of fetal origin. And this can be done after 9 weeks. But remember that both amniocentesis and CVS do put the baby and the mother both at risk for infection and miscarriage because you're sticking a needle into those areas and giving a direct route for the bacteria to follow. All right, so let's move on to Chapter 5, menstrual cycle. So teens need factual information, or even preteens need factual information regarding menstrual cycle. So the definition of a cycle is the first day of menses is the first day of the cycle to the first day of the next menses. So first day of this cycle to the next time that I get my period is a full cycle. So cycle length averages about 29 days and ranges from 21 to 35 days. Again, this is average. This isn't for everybody. The amount of flow is usually 25 to 60 milliliters per period. And the length of menses is anywhere from 2 to 8 days typical. Now, what do we need to educate these people about, or females rather? So we need to educate them about pads and tampons. So there are reusable menstrual pads made of washable cotton, menstrual cups like the Diva cup that actually is kind of like a cup that you put up into the vagina and it collects the drippings, and then you take it out and empty it and you can put it back in. There's also menstrual sponges that absorb. Tampons can range in absorbency. So the super absorbent tampons have been linked to toxic shock syndrome, and Staph aureus is the causative organism and frequently found on the hands. So make sure you instruct them to wash their hands before inserting the tampon, and avoid touching the tip, because if they have it in their hand, they touch the tip, then of course it's going to go into the vagina. Now make sure they use tampons with minimum absorbency necessary to control the flow, and change them every 3 to 6 hours. So they shouldn't be sleeping with these either. And avoid using them for vaginal discharge or light bleeding. It can actually dry out the vagina, and then it can cause ulcerations in there. So we don't want any of that to happen. Make sure that when you talk to them, make sure that you know, or they know, how to insert them as well. I can relate to that with my mother saying, okay, here's a tampon, and then you just put it in. That's all it is. I wanted to go swimming with my friends, and I'd never used one before, so I had to learn pretty quickly. So I put it in, but I didn't take out the plastic piece. And I know you're probably giggling, females, because you're like, well, you're supposed to take it out. Well, I didn't know. Mom didn't tell me. Take out the plastic piece. You put it in there, you take that plastic piece out, or cardboard. So I went swimming, and part of the way through, I was like, oh, this is uncomfortable. So I took it out, and it was like, oh my gosh, that's so much better. And I remember telling Mom, if you take that out, it's so much more comfortable. And she's like, oh, you dork. She's like, you're supposed to take it out. Well, how was I supposed to know? She didn't tell me. And I wasn't going to sit there and read that paper. So make sure that you tell them things like that. Also, that there's different types of pads and sizes for those too. So help them pick out the most appropriate, or educate them on the most appropriate as well. And I do want to add a caveat to make sure that they understand their normal body anatomy, because I also had a friend in high school who I took A&P with, who thought that her vagina was where she also peed out of. So she thought every time she went to the bathroom that she had to change her tampon. So she didn't understand that those were two separate different holes. So I had to educate her on that. But it's common misconceptions, things that you assume that they know. They don't know what they don't know. So make sure that you educate them on that. Let's talk about vaginal sprays, douching, and cleansing. None of that is actually necessary because the body naturally does that every month when we shed the endometrial lining. Sprays can actually cause infections and itching and burning, vaginal discharges and rashes. And douching can actually upset the vaginal flora and cause reactions. It can cause bacteria and germs to actually enter the uterus by forcing that water upward as you're cleaning. And then we always want to encourage the use of cotton underwear because it lets your body breathe a little more. And bacteria and fungus or yeast likes to grow in dark, moist places, and that's the perfect thing for something like that. So make sure that they wear cotton underwear. You want to encourage them to wear loose clothing, wipe from front to back, and wash with plain soap and water to control odor, especially during menses. So they need to know every day that you have your menses, you need to take a shower because that is old blood and it stinks. Women, I'm sure you can attest to walking into the women's bathroom, whether you know who's in there or not, or whether they have their period or not. If someone's in there and they have their period, you usually can smell it. So it's just something that that needs to be done. And tell the teenagers or preteens, you want to do that because you don't want to smell. And if they're really into boys, they're never going to get a boy that way. There is a great review on page 72, table 4.2 of the female reproductive cycle, and pictures on page 69 that may also help you with understanding the menstrual cycle a little better. All right, amenorrhea, which is the absence of menses. Primary is within the 4 years of breast development and no menstruation by age 16, and causes can be from hormones or congenital obstructions. And secondary is established menses, longer than 3 months, but then it stops for 6 months. And usually this happens because of pregnancy. Now, premenstrual syndrome, or PMS, is usually occurs between ovulation and onset of menses, usually during the luteal phase, which is 2 weeks before your menses. And there's a lot of psychological and somatic effects, some other side effects like irritability, lethargy, depression, low morale, anxiety, sleep disorders, crying spells, migraine, vertigo, syncope, nausea and vomiting, constipation, bloating, cravings, retention, oliguria, acne, swelling and tenderness, or joint or muscle pain. Really the causes are unknown, but the thought is that it's caused by progesterone and estradiol levels, and risk factors can actually predispose a woman, such as having extra stress or traumatic life events, genetics, obesity, or a history of depression. So that can actually make things worse or cause them. Now, there's also a thing called premenstrual dysphoric disorder. This is more serious symptoms and are primarily mood related and pretty severe. So a lot of times we give SSRIs to help with that, especially if they have the depression, and it helps stabilize those moods that they have. Now, how do we take care of all this? How do we manage it? A lot of times we encourage restricting foods with methylxanthines, such as chocolate, cola, coffee, alcohol, nicotine, red meat, salt, and sugar, and increase the intake of complex carbs, proteins, and then increase the frequency of meals. So it doesn't mean eat bigger meals more often. It just means maybe eat a few smaller meals more often throughout the day can happen. And I know you heard me say chocolate and things like that. So yes, that's something that we actually want people to restrict because of the methylxanthines that it has in it. Now, some other things that we can do to help manage is some aerobic exercise, and then even some vitamins like B vitamins, which can help with anxiety and depression, or E vitamins that can help with breast tenderness. Calcium relieves certain physical and psychological symptoms, and magnesium for fluid retention and bloating. But there are also herbal remedies if someone is looking into that. All right, gynecologic problems, menstrual cycle disorders. So primary dysmenorrhea, painful menstrual flow is basically what it is. It usually occurs in teens and early 20s. It begins with the day before or onset of menstrual flow and lasts 12 to 72 hours. And increased production and release of prostaglandins actually stimulate the myometrium and causes severe spasms, which constrict the uterine blood flow, which results in ischemia or death, and then the pain in that area. So that's what causes all that cramping. So it does typically disappear after the first pregnancy, and doesn't occur if cycles are anovulatory. So if someone doesn't ovulate, then that usually doesn't happen. However, women who have had children know that they still have some cramping, but usually by the time that your uterus goes back to its normal size, which is about 6 weeks, that cramping goes away, and you usually don't have that with any subsequent periods that you have. Typically, again, not for everybody. So how are we going to manage our painful menstruation? So a lot of times we encourage heat via heating pad, or a bath may decrease cramping due to the vasodilation and muscle relaxation. Massage of the lower back, application of cold, aerobic exercises like swimming and yoga, NSAIDs, or oral contraceptives. And the reason why oral contraceptives work is because it inhibits the ovulation. And when that happens, then we don't have the pain, because like I said, being anovulatory, so not ovulating, will actually not give us any painful menstruation. Let's talk about contraception. So the nurse's responsibility is to educate and inform the clients about use, side effects, and effectiveness of different contraceptive options, so that the client can select one that meets her needs or her and her partner's needs. Now, some considerations that need to be taken considered are cultural, religious beliefs, personal preferences, financial resources, attitudes, and values. And their decisions should be voluntary with the full knowledge of all the available choices, advantages, disadvantages, the effectiveness, the side effects, contraindications, and the long-term effects of those contraceptions. Now, contraception, fertility awareness. This includes women monitoring her fertile window, generally between days 8 and 19 in a 26 to 32 day cycle, and use a barrier method during that time. So most fertile days, 5 days before ovulation until 1 day post ovulation. I always say if you're gonna use something for those 6 days, you might as well do it for that 7th day and make it a whole week. So essentially what the female does is they use a number of methods to figure out when they typically ovulate, and then they work around that. So they may use the ovulation kits that they have out there. She may check her mucus. She may check her temperature every morning to figure out when she ovulates. And then what happens is, sometimes they call it the rhythm method, is, the weeks that she knows she's not highly fertile, they don't use any protection. But then that 1 week that she knows that she's going to be ovulating and that she can be fertile or become pregnant, they use contraceptives like condoms or female condoms or whatever it is that they want to use. And the other weeks after that, the last 2 weeks, they usually don't use anything again. Now, barrier methods of contraceptives, those include condoms, both male and female, diaphragms and cervical caps that cover the cervix to eliminate the sperm fertilizing the egg, Vaginal sponges that also fit over the cervix and has a spermicide in it. Then there's also uterine devices, or IUDs, which are inserted into the uterus by a healthcare provider and left in place for an extended period of time and provides continuous contraceptives for anywhere from 3 to 10 years. Nexplanon replaces the Implanon. It's a single capsule implanted and inserted subdermally in the woman's non-dominant upper arm and is effective for 3 years. It could be more than that now too. And then there's oral contraceptives. And those have different combinations of estrogen and or progesterone, depending on what the person needs, or maybe even their diagnosis or previous medical history. They may be allowed one or the other. Hormonal contraceptive emergency postcoital contraceptives. Now, I never knew what coitus was until I watched Big Bang Theory. Thank you to Sheldon Cooper. I now know what that word actually means. Now, they have what's called the morning after progesterone. It's morning after pill. You take the first pill as soon as after intercourse as possible and before 72 hours, and a second pill 12 hours later. However, studies have shown that if you give one large dose, it's just as effective as taking those two. And then a lot of times it's used after sexual assault to prevent pregnancy, and it's over the counter, so it's pretty easy to get. Now, you can also have permanent sterilization, such as a tubal ligation, which can be, your tubes can be clipped, litigated, electrocoagulated, banded, or plugged, and can be done laparoscopically, or it can be done vaginally. And we make sure we instruct these clients about these different methods and that they're considered to be irreversible. They can be reversible nowadays, but it depends to what extent they're done. The other thing is that you need, if a micro insert is done to clamp, make sure they do a 3-month checkup to make sure that things aren't opened back up and that things are truly closed. They also are doing cutting out the full fallopian tubes because they're finding, or there's still lots of research out there and it's still debatable, but they're kind of figuring that ovarian cancer grows in the fallopian tubes. So if you remove those fallopian tubes, you decrease the woman's risk of getting ovarian cancer. Now, the difference between removing and just like snipping or tying or whatever is they only cut out 1 inch typically, if they actually truly cut it out. To do the tubal ligation, where when they fully remove the tubes, it's only an extra 4 inches or so, and it only takes 15 minutes longer in the actual surgery if you were doing a laparoscopic surgery to do it. And then for the males, there's the vasectomy, where they sever the vas deferens on both sides of the scrotum, and it takes about 4 to 6 weeks or 6 to 36 ejaculations to clear the remaining sperm and the vas deferens. Again, make sure that they do a 3-month checkup, so that way they can check their sperm or check their sample and make sure there are no sperm in there, to make sure that it truly is or they truly are sterilized at that point. Recommended gynecologic screening procedures. So breast self-exams. According to the U.S. Preventative Service Task Force in November of 2009, it was recommended against teaching women breast self-examination based on the studies they reviewed that actually suggested they did not reduce breast cancer mortality, but resulted in additional imaging procedures and biopsies. However, women should still be aware of how their breasts normally look and feel. So it's not necessarily a bad thing. It just results in more imaging and things. And another little additive tidbit is a lot of times the significant other of the female is the one that actually finds any lumps or bumps or the breast cancer before the woman actually realizes it's there. Now, mammography, the ACS recommends annual mammograms with women ages 45 until 54, and then every other year for average risk women after that. The mammogram is basically a soft tissue x-ray of the breast without contrast. The newer machines don't hurt quite as much as they squish the tissue of the breast together. So that's good. They're starting to come a little ways with that. Now, pap smears and pelvic exams. A pelvic exam or pap smear is a cervical cytology test used to detect cellular abnormalities by examining a sample from the cervix and endocervical canal. And the annual recommendations there for women is 18, or if they're early to have coitus, they may want to start doing them earlier. A lot of times they use the liquid-based medium pap smear as the method of choice for cervical cancer screening. And it's also more accurate and allows for some STI screening and HPV screening too. All right, menopause. So menopause is the absence of menses for 1 full year. The median age there is 50 to 51. So it's also called the change of life, or the maturation change in a woman's life. So psychological changes, the menses stops, hot flashes or vasomotor disturbances occur, palpitations, dizziness, increased perspiration at night. Physical changes like the vagina atrophies of the vagina, so vaginal atrophy. They may need to use water-based lubricants for intercourse. Vaginal pH increases, and then dryness of the mucous membranes can cause itching and burning, or sometimes ulcerations. Also, osteoporosis is an increased concern here, so a lot of times we encourage them to use calcium supplements and increase their exercise so that way they don't break their bones. Management, again, we educate and prevent osteoporosis. Hormone replacement therapy or menopausal hormone therapy, it's called both. A lot of times used with estrogen or without progesterone. It has estrogen and used with or without progesterone, but a lot of times we're seeing this used less often because it actually increases the woman's risk for cancer, and also DVTs. The same with oral contraceptives, that increases the woman's chances for DVTs as well. All right, Chapter 6, gynecological problems. So fibrocystic breast disease. Fibrocystic breast changes are benign breast diseases. Fibrosis is thickening of the normal breast tissue and cyst formation that may accompany fibrosis. The cause is unknown, but a lot of times people complain of pain or tenderness and swelling. The breast may feel dense, irregular, nodular, or lumpiness. A lot of times it can express some nipple discharge out of one side, but if it's both sides, that can be worrisome for some breast cancer. Fibroadenoma is a benign tumor for women in teens and early 20s, and that's freely movable, solid tumor. It's kind of rubbery, asymptomatic, and non-tender. So a lot of times they won't do anything about it unless it's big enough that it's is becoming a problem, or if you want to remove just for the sake of removing because you're not sure if it truly is cancerous or not. Then there's duct ectasis or condylomastitis, which is inflammation of the duct behind that nipple. Usually occurs during or near menopause, and women who have born and breastfed infants are usually the ones who end up getting this. Toxic shock syndrome, we talked about real briefly. Again, it's caused by the Staph aureus. It gives you flu-like symptoms for the first 24 hours. So a high fever, headache, sore throat, vomiting, diarrhea, rash, resembling a severe sunburn, hypertension, multi-system involvement, and a lot of times it's the most common in women of childbearing age, which would make sense since usually women of childbearing age have their period and are using tampons. So there's an increased incidence of women who use the tampons or barrier methods of contraceptives such as diaphragms and cervical caps. And how we treat that is by fluid replacement and with antibiotics. Endometriosis is the presence and growth of endometrial tissue outside of the uterus. A lot of times they can have pelvic pain related to menstruation itself and painful intercourse, or abnormal uterine bleeding or infertility. During or immediately after menstruation, the tissue bleeds, resulting in an inflammatory response. So you can have scarring from the bleeding or adhesions to adjacent organs. So down here in your picture, you'll see that there's some black spots. Those are some different areas that it can migrate to, but it can literally be about anywhere in the body, just because it can navigate. So if I have some endometrial tissue, let's say up by my lung, well, when I go to have my period, things will become inflamed. That'll become really sore. And then it can cause that scar tissue and adhesions and stuff. And those adhesions can cause other issues, constricting things, or pain itself. Now, endometrial tissue migrates through the fallopian tube is the main accepted theory. Otherwise, they're not 100% sure how it gets transmitted. But another thought is by immune genetic, it could be caused by immune or genetic or environmental factors, or vascular and lymphatic dissemination, where it's transported through the body to foreign locations through the lymphatic system or the vascular system. Polycystic ovary disease. Oh, sorry. I wanted to go back here and just let you know that the treatment for these people with endometriosis includes medical with a focus on suppression of the menstrual cycles through hormonal treatments. So they can once either surgically remove the adhesions or endometrial implants. And if it's severe enough, they may need a hysterectomy with bilateral salpingo-oophorectomy, which is basically a total hysterectomy, removing the fallopian tubes and the ovaries. Now, if they stop the menstrual cycle, that would stop the endometrium from becoming inflamed or shedding. And so then, therefore, it stops the pain that has occurred with it. Oh, I'm hitting the back button. Sorry, guys. There we go, back on track. Polycystic ovary disease. So high levels of luteinizing hormone overstimulates the ovaries and then produces multiple cysts on those ovaries. These cysts produce high levels of estrogen, and typical patients are usually obese. They have irregular menses, have hyperinsulinemia, hirsutism, which is the abnormal growth of hair, like on the face for females. And then a lot of times people are infertile because of it. So the treatments are oral contraceptives to inhibit the luteinizing hormone production. They can have bilateral salpingo-oophorectomy, so that could be the removal of the fallopian tubes and the ovaries, and then a hysterectomy, a total hysterectomy if needed. And if they want to get pregnant, a lot of times they use Clomid to stimulate that ovulation. Now, the goals for people with polycystic ovarian disease is to regulate their menstrual cycles, thereby protecting the endometrium and decreasing risk for uterine cancer. And then they can also improve the acne, give metformin for tissue sensitivity to the insulin, lose weight, they can have lifestyle changes, and then they can actually stop smoking, which would help the disease. Bacterial vaginosis. It is not an STD. It's an alteration in the normal bacterial flora. The cause is unknown, but thought that the tissue trauma from douching, frequent sexual intercourse without a condom, and upset in normal vaginal flora can be caused by it. Thin, watery, white discharge is usually what they see, and they can have clue cells, which is actually what's being shown in the picture here. And the treatment of choice is usually flagyl. And make sure that we educate the patients that women should avoid intercourse or use condoms during the treatment, and infection during pregnancy can lead to premature rupture of membrane or preterm labor. Vulvovaginal candidias is a fungal infection or a yeast infection, as we commonly know it as. Causes are by antibiotics, douching, pregnancy, and diabetes. A lot of times they have thick, curdy discharge, itching, or dysuria. It's usually shows hyphae and spores upon the slide examination, which is what you see on your picture. And treatment here is miconazole or nystatin, and it's over the counter a lot of times, but you can get prescriptions. So in helping to prevent this, we encourage people to wear cotton underwear, avoid vaginal powders or sprays, complete the course of their medication so it doesn't come back, and then eat yogurt with the use of activated live cultures. Or, because it's got the live cultures, it can actually be used as a douche, which I find quite interesting. And then they can use probiotics, which may also help in this. Trichomonas is a microscopic motile protozoan, which thrives on alkaline environments. It's acquired through sexual intimacy, but rare fomite transmission can be done through shared bath facilities, wet towels, or wet swimming suits. A yellow and green frothy discharge may be seen. Inflammation of the vagina and cervix. And then flagyls given for both partners. And then we need to remind them that they shouldn't be drinking alcohol while on that either. Chlamydial infection is the most reported in the U.S. It's the world's leading cause of preventable blindness, and that's basically because when a pregnant woman has it and gives birth to her child, the child can get it across their face as they're coming through the birthing canal, and actually that leads to blindness. So a lot of times we give babies erythromycin ointment as soon as they're born to help prevent that. Males usually notice urethritis, and females, this can lead to the pelvic inflammatory disease, infertility, or ectopic pregnancy. A lot of times people can be asymptomatic, and a thin purulent discharge or dysuria or lower abdominal pain can occur with this. And treatment's usually azithromycin or doxycycline. Gonorrhea. So Neisseria gonorrhea is asymptomatic. Pregnant women have the mucus plug, so it helps it from going up into the uterus where the baby is. Newborns, again, get erythromycin to help fight against it. They usually have a purulent greenish discharge. Urethritis and discharge are usually what males see. And men usually seek treatment sooner due to their symptoms, and then the woman needs to be treated as well. Usually we give ceftriaxone plus we give treatment for chlamydia because a lot of times we see these together. Now herpes, herpes simplex virus 1 are cold sores on the face or the mouth, and herpes simplex virus 2 is genital herpes. Now they can be transferred through oral genital contact, so if someone goes down on their partner, then they would have potential herpes on their face. Now, blisters can appear within a few hours to 20 days after exposure and rupture spontaneously to form painful, open, ulcerated lesions. Lesions then usually heal and enter a dormant phase before reoccurring again. Now, some people only get it once and others get it recurrently. There really isn't any cure for it. We give acyclovir when it is in the active stage. And then we encourage them to wear loose-fitting clothing, cotton underwear, or none at all because it is painful. And then make sure that they keep the genital area clean and dry. That'll help with symptoms as well. Syphilis is transmitted through vaginal, oral, or anal sex. Tryponium pallium is what its main organism is. It can, early or in the primary stage, it can cause chancre or sore. Secondary symptoms are rash on the palms and soles of the hands and feet, arthritis, enlarged liver and spleen, non-tender enlarged lymph nodes, and chronic sore throat. It's usually transmitted transplacentally, so it can go to the baby. And then penicillin is a treatment of choice here. So Condylomata acuminata is venereal warts, much easier said that way. It causes human papillomavirus, which has over 100 subtypes. It causes wart-like lesions, and you have it 3 weeks to 3 years after the exposure. It can be treated with cryotherapy with liquid nitrogen to kind of burn them off, or they can be surgically removed. A lot of times, kids now get Gardasil. There's like a series of like 3 shots to help prevent against HPV. All right, care of the woman with a pelvic inflammatory disease. So inflammatory disorders of the upper female genital tract that include endometritis, salpingitis, tubal-ovarian abscesses, pelvic abscesses, and pelvic peritonitis. Pelvic inflammatory disease occurrences. So they can occur with multiple sexual partners, if someone's got a history of pelvic inflammatory disease, recent insertion of intrauterine devices, and regular douching can predispose them or have that reoccur. Now, the organisms most frequently identified are trichomonas and gonorrhea. Symptoms include bilateral sharp cramping pain in lower quad, fever, chills, purulent vaginal discharge, irregular bleeding, malaise, nausea and vomiting, or asymptomatic. It can cause infertility. And a lot of times our treatment is IV fluids, pain meds, IV antibiotics of cefoxitin or cefotaine plus doxycycline. And then nursing management would just be to educate. Now, uterine leiomyomas, basically fibroids, are benign and slow growing. They develop within the uterine wall. The cause is usually unknown and they're asymptomatic, so they don't need any treatment unless, of course, they're quite large and they start pressing on things. Then they may have them removed. A lot of times they have abnormal bleeding, pelvic pressure, constipation, or urinary frequency, or painful sexual intercourse. Pelvic relaxation. So a cystocele is a downward displacement of the bladder, which appears as a bulge in the anterior vaginal wall. So symptoms can include loss of urine with coughing, sneezing, laughing, or sudden exertion. It can also feel like a vaginal fullness, bulging out of the vaginal wall, or dragging sensation. So we encourage them to do Kegel exercises to help strengthen those muscles. Estrogen can improve the mucus lining and may result from a decreased pelvic support as woman progresses through menopause, childbearing, obesity, and genetics can play a role. Now, rectocele. The posterior vaginal wall is weakened, and the anterior wall of the rectum can then sag forward, ballooning into the vagina, pushing the weakened posterior of the vagina in front of it. So it may result from decreased pelvic support, or sorry, that was the other one. The rectocele here, if you can see, right here is the normal rectum. And then in a rectocele, that rectum kind of pouches out and pushes into the vagina and can pouch out where you can see it out of the vagina. And sometimes that we actually have to lubricate and then push that back in to the vagina area and back where it should go. And then there's also uterine prolapse, when the uterus protrudes downward into the upper vagina, pulling the vagina with it. A dragging sensation, backache over the sacrum are pretty common. Treatments with topical or systemic estrogen and vaginal pessaries or surgery for hysterectomy and repair can be done. So again, here in our picture, this is where it normally is, but it kind of falls down into the vagina. And again, we can lubricate that and push that back up to where it's supposed to go, or they can have a pessary that will kind of hold it in place, or they can do surgery and kind of sew it back into place for really any of these that can help with those. Infertility. So a couple is considered infertile when they do not conceive after 1 year of unprotected sex. Collect a thorough history and physical exam of both partners. So infertility possible causes, 20% is usually male, 40% female, and 40% is usually undetermined between the two. And then professional intervention can usually help with about 65% of infertile couples, which is pretty good. It's more commonly discussed now, and a lot of times that's related because the delay of age of childbirth, so people are waiting to have kids, and then an increased availability of treatment is now out there. So the nurse's role is to provide education regarding and identifying the most fertile time of a cycle and how to identify the signs and symptoms of ovulation. Now, we also need to remember that this can be a really emotional point of time for the couple and the mother-to-be. So we need to make sure that we have lots of support to help them avoid feelings of guilt and blame, because a lot of times they turn that in on themselves. So normal fertility components and possible causes of infertility. We need to teach the female how to determine the time of ovulation, so they can check the favorable cervical mucus or the Sparrgrove theory, which basically the mucus can be stretched 8 to 10 centimeters or longer and helps sperm to survive in the thin, clear, watery, profuse alkaline mucus. They make sure that there's a clear passage between the cervix and the tubes, that there's no physical barriers there internally. Make sure that the tubes are patent with no motility, ovulation, so to make sure that the body's actually ovulating, releasing an egg. No obstruction between the ovary and the tubes. And then endometrial preparation, so make sure that there's good hormonal control, so like the FSH and the LH, and then they can actually check progesterone assays. Now the male is the easiest to evaluate because they give a sample and then they look at it and look at the quality, quantity, and motility. They look to see if there's any obstructions in the genital tract, and they look for the genital tract secretions. And then the other thing that they can check is to make sure that when they're having intercourse, that the man is actually able to get the sperm to the cervix, so that way it can make it through it up into the uterus and to the fallopian tubes where it can be fertilized. So fertility workup, so what do they normally do? They can do a hysterosalpingography, or HSG. So it's an evaluation of the uterine structures and tubal patency. So that's usually done by an X-ray to look at the tube patency. They can do a laparoscopy. So they use that only if there's strong clinical suspicion that there's something going on. It's more aggressive with higher risks and or costs. It can cause organ displacement, shoulder and chest pain from gas in the abdomen as well. And that's a direct look at those pelvic organs and is considered a surgical procedure. They can test the man, seeing if there's anything there. And when we test the man, it centers around that semen analysis. So they collect the semen 2 to 3 days after the abstinence, so that way they have a good sample. And then the normal semen analysis, if you want to know what they're really checking for, is on table 6.5 in your book. Infertility management, pharmacological methods. So medications can maybe prescribed to induce ovulations, facilitate cervical mucus formation, like on figure 6.7, reduce antibody concentration, increase sperm count and motility, suppress endometriosis. And a lot of times they can do therapeutic insemination, which is artificially insemination, depositing semen at the cervical os by mechanical means. It can be done with a therapeutic husband insemination. So the husband, you use his sperm, or a donor's. Then there's in vitro fertilization, which is IVF, which the woman's ovaries stimulate one or more oocytes, and then it's aspirated, fertilized in the lab, and placed back into her uterus. Then there's gamete intrafallopian transfer, or GIFT. The retrieval of the oocyte is done by a laparoscopy. Immediate placement in a catheter with washed motile sperm, and place the gametes back into the fimbriated end of the fallopian tube. And then the fertilization doesn't actually occur outside the woman's body. It still ends up happening in that fallopian tube. So for some religions, that is an accepted format because the fertilization didn't actually happen outside of the body. And then there's tubal embryo transfer, TET. The eggs are retrieved and incubated with the sperm. Eggs are transferred back into the body in an earlier stage of cell division than IVF and GIFT. Then they're placed in the fallopian tube. And placement's done at the embryo stage, and theoretically increasing the pregnancy rate when placed in the fallopian tube. So it's better if you do that. And then not only the evening class, but day class, I also want you to work on your fetal circulation worksheet. Now, if you printed it a little early, you may not have on there that you need to work on the fetal circulation picture and color that in and label that as well, but that is something that I still want you to do. So watch the Khan Academy video and fill in the fetal circulation picture and color it and label it. And then I want you to do that fertile circulation and signs of pregnancy worksheet as well. And that is it.